first rib joint play. So what test do you all know is available to assess for an elevated first rib? You guys remember the test? Yeah, close. Yeah. So cervical rotation, lateral flexion. So what you do is in the name and in the order. So it's all passive range of motion. So passive, full cervical rotation. You maintain your hand contact and then laterally flex. You are looking for an asymmetry in the amount of lateral flexion from one side versus the other. So as I'm performing the test on this side, which first rib am I assessing?
Contralateral rotation.
Yep, so we're assessing the right side, okay? In theory, the theory behind it is that if the rib was elevated, we'd see less lateral flexion, potentially because there's now an abutment between the lower cervical transverse processes in the first rib. You guys tracking with that so far? So you're gonna practice that on your partners first to see if anybody has an asymmetry side to side. Now for treatment, in supine, we can also do this in seated, but in supine, we're gonna come from behind to find the first rib. So remember the skeleton, right? The first rib is pretty prominent, and posteriorly, it's above the location of the clavicle. So it comes off the spine. So you can always find your spinous process, palpate laterally, and you're gonna feel almost like a flat ridge. So you can even try to find it on yourself. Like a flat ridge just lateral to the cervical spine. It's tender in a lot of us because what muscle is attached there? You got it, yeah, the scalenes. Okay, but that flat ridge is what you're gonna hook onto with your first MCP joint. Okay, now it's a lot easier to find it if we take tension out of the upper trapezius muscle, because then it helps us to kind of get the upper trap out of the way to get to that bony landmark. So to do that with your patient in supine, you're gonna deflect or reflect really the upper trap forward. So you're gonna kind of move it out of the way from posterior to anterior, and I'm using the side of my first MCP joint there to do that, okay? So I'm moving it out of the way so that I can hook onto the posterior and really like superior surface of the first rib. Then I'm gonna rotate passively and just let the pillow stabilize my partner's head to take tension off of that muscle. You'll feel the first rib become a little bit more prominent as that happens, and that's how you can confirm that you're on the right spot. The direction of our force is not straight inferior, it's inferior and a little lateral towards the opposite hip. So I wanna get in the direction of my force. To do that, I'm gonna step to the side, I'm gonna stagger my stance, and I'm gonna brace my trunk against my elbow so that I can drive my force from my elbow towards the opposite hip. How are we doing with that? This hand is just gonna maintain a neutral position for the head in that rotated position. Okay, so we're trying to avoid excessive flexion and extension or side bending. We're trying to keep it more just pure rotation there. So no extra force really, I'm just stabilizing as I start to assess joint play. So I'm gonna come inferior, lateral towards the opposite hip. Inferior medial really. So inferior medial towards the opposite hip. How you doing with that? Okay. You wanna check in with your patient, okay, and your partner to see how that feels. So if you're getting any like pins and needles, electric shocks, or significant tenderness, you're gonna change your hand position. You're gonna move a little bit more lateral to avoid really the superior part of the brachial plexus. And you might have to flatten your hand a bit to get more of a broader contact point onto the first rib so that it's not as tender. Okay? Okay, let's try that.